Am I audible?
Yes, ma'am.
Good afternoon, everyone. We welcome all the PGs and the consultant pathologists joining us online to the KCIAPM Virtual Slide Seminar from Neuberg Anand Reference Laboratory, Bangalore. We will have 6 interesting cases that will be presented by 6 PGs representing from different medical colleges. We request you to share the web link to your colleagues and postgraduate students and encourage them to watch and participate in this live webinar. Kindly set your YouTube resolution at 720 pixel for the clear images. Feel free to post queries in the chat section and we will be taking the questions from the chat box. Each PG will be allotted 4 minutes to present the case. Kindly restrict presentation to histomorphological descriptions and differential diagnosis. The case 1 will be presented by Ami Srivastava from SDM College, Dharwad. Over to you.
Dr. Avani, please unmute yourself and start sharing your PowerPoint presentation.
Am I audible, sir?
Yes, you're audible. Please share your PowerPoint and begin your presentation.
Yes. Is it okay, sir?
Yes, please go ahead.
KCIAPM Feb 2021 case 1. 50-year-old female received total thyroidectomy specimen with sir, I'm not able to read it. It's 50-year-old female received total. Okay, sir. Received total thyroidectomy specimen. Colloid goiter in right lobe. Right lobe measures 9 into 7 into 4 centimeter. Left lobe measures 4 into 2 into 1 centimeter. Cut section shows a single whitish nodule measuring 8 into 6 into 4 centimeter with the cystic changes. In the low magnification, insular pattern can be seen with the follicular arrangement of the cells with the varying sizes of the follicles. Pseudopapilly can be seen in the low magnification with the without the fibrovascular. The calcifications are seen in most of the cases. The pseudomatous-like calcifications are seen with the cells round to oval with eccentric nucleus, coarse chromatin, and prominent nuclei with clear cytoplasm. The calcifications without laminations also been seen in most of the cases. The capsular invasion are seen, and the tumor cells are the capsule is infiltrated by the tumor cells. In this area, the predominant follicular pattern has been seen with the cells morphologies is still the same. It is the clear cells are seen with a few of the trabecular pattern, and predominantly follicular pattern has been seen. The pinkish amorphous material seen in most of the focus. The clear cells are seen in diffuse sheet pattern. The hyalinized and sclerosed areas are seen. The coagulative necrosis and the ghost RBCs are seen in one of the focus. My findings are the arrangement predominantly is follicular, sheet-like, solid sheet-like, pseudopapilly and trabecular pattern. Morphology, the clear cells with eccentric nucleus, post-chromatin and clear cytoplasm. The calcification, pseudomatous-like, and few are without laminations. Capsular invasion seen, coagulative necrosis seen with ghost RBCs, and few hyalinized and sclerosed areas also seen. So my differential diagnosis sticks to the poorly differentiated insular carcinoma, papillary carcinoma, follicular variant, Lindsay tumor, mixed medullary and follicular carcinoma, and oncocytic Hurther cell carcinoma. Being in the papillary carcinoma follicular variant, in spite of the predominant follicular pattern, there is no nuclear features present. So we can rule out the papillary carcinoma follicular variant. The mixed medullary and follicular carcinoma. In the mixed medullary carcinoma, by virtue of the growth pattern and amyloid-like sclerosis, it can be recognized by more prominent vasculature and granular cytoplasm. and it can be confirmed later on by thyroglobulin and calcitonin. And in the follicular carcinoma, there will be no necrosis. In oncocytic arterial cell carcinoma, because of the capsular invasion and a few calcification without laminations and ballooning of the cells and plasmacytoid like few of the plasmacytoid like cells, oncocytic carcinoma can be one of the differential diagnosis. But my probable diagnosis will be poorly differentiated insular carcinoma only. The features which suggested, which favors my diagnosis is it is having, the slide is having the classical insular pattern. The age is the older, mean age group is 50 to 60 years. The third is the Turing consensus criteria, which is the presence of the absence of the nuclear features of the papillary carcinoma, which is present here. And there should be presence of any of the following, that is mitosis more than 3/10 high power field, necrosis should be present, and convoluted nuclei. In this, one of the feature, that is necrosis, is present, and there is absence of the nuclear features. And for the follicular for the calcifications, it can be because it is poorly differentiated, the residual calcifications can be seen. So my differential diagnosis is my probable diagnosis is poorly differentiated carcinoma, and later on we can confirm it by keratin, thyroglobulin, TTF1, and Ki-67. Thank you.
Hello, Rakshit, you're not audible now.
Yeah. Is the screen visible now?
Dr. Rakshit, you're not audible.
Yeah. Audible?
Dr. Rakshit, you're not audible. Just go to the settings, just check the mic again, and then go ahead and share your PPT.
Audible now?
Yeah, better.
Yeah.
Please share your PowerPoint and then go ahead.
Dr. Shruti will be presenting case number 1. Is the screen visible?
Is the screen visible now?
No, not yet. Dr. Rakshit, please help her share the PowerPoint. No? Yes, it's up now. Please make it full screen and avoid the presenter mode.
Good afternoon, everyone.
Please switch to presenter mode. Dr. Rakshit, go to display settings and yeah. Please go ahead now. Thank you.
I'll be discussing the first case of the slide seminar. We received a total thyroidectomy specimen from 50 years old female. Grossly, it was the right lobe was 9 by 7 by 4 centimeters. Left lobe was 4 by 2 by 1 centimeter. Right lobe had a nodular external surface. No breach in the capsule was seen, and external surface had prominent congested blood vessels. On cut section, it was a single whitish nodule measuring 8 by 6 by 4 centimeters. As we can see here, there are multiple cystic spaces containing mucinous material. Microscopically, it is a infiltrating tumor composed of cells arranged in tubular pattern, glandular pattern, and also in the sheaths, and in the few areas it had cells arranged in the cribriform pattern as well. Going to the high power, these glandular areas were lined by intermediate type of cells. They are cuboidal cells with mild anisonucleosis having moderate amount of eosinophilic cytoplasm, and also there were few, most of the areas were containing clusters and singly scattered cells which were having clear cytoplasm. They are looking like a mucin secreting cells with peripherally and centrally to peripherally placed nucleus with cytoplasm having abundant mucin. Also, there are sheets of cells which appeared squamoid. These are the cribriform areas. There were also extracellular mucin in few of the tubules. This is also extracellular mucin. And we could also see lymphovascular emboli and containing these mucin secreting cells as well as intermediate type of cells. So we went ahead with special stain like Alcian blue stain, where this mucin was taken up positive for Alcian blue. Even the extracellular mucin and the cells had taken up Alcian blue. So compiling all these features, can anyone think of any diagnosis? You have 20 seconds time to reply in the chat box.
Dr. Minesh Gandhi says mucoepidermoid carcinoma in the chat box.
Okay.
Anybody
Any
else?
responses?
Dr. Anusha also says mucoepidermoid.
Okay.
Okay.
Okay, that's it. So the responses which we received were hyalinizing. I'll discuss the responses. Hyalinizing trabecular adenoma. First of all, we have multiple lymphovascular emboli. So it is not adenoma. And in hyalinizing trabecular, we should have prominent nuclear grooves, which were not present in this case. Follicular carcinoma with nodular goiter. The arrangement of cells was looking like follicular, but the mucin secreting cells and extracellular mucin is not a feature of follicular carcinoma. Then the follicular variant of papillary carcinoma. We didn't have any nuclear features of papillary carcinoma here, like clearing or any inclusions. Medullary carcinoma, there was no amyloid-like material. It was a hyaline, and the mucoid material which was present. There was no amyloid-like material, and paraganglioma, the arrangement of cells, the sheets of the organoid pattern of cells and the nuclear features were not fitting into paraganglioma. So compiling all these features, the final diagnosis was mucoepidermal carcinoma of thyroid. It is a very rare mucoepidermal carcinoma, mainly occurs in the salivary gland. It is a rare occurrence in the thyroid, less than 0.5% of all the thyroid carcinomas. It is a malignant epithelial neoplasm. Incidence is mainly in the 4th to 5th decade, female preponderance. Origin of this tumor in the thyroid is said to be from the ectopic salivary gland rests which are present in the thyroid, and also the remnant of the thyroglossal duct, the lining epithelium, the mucinous lining epithelium of the thyroglossal duct, that may be the origin of this tumor, or metaplasia of the follicular cells. Clinically, the patient will be euthyroid. It presents as a cold nodule. It is mainly histopathological diagnosis, but IHC can be done. Keratin will be positive, PAC8 will be positive, and TTF1 will be negative here. Prognosis-wise, it is a low-grade tumor with indolent behavior. Extrathyroid extension is very rare, and metastasis is very less likely, less than 10% of the cases. If it occurs, it may occur in the lung. These are my references. Any questions anyone has in the chat box? Yes. Questions?
Nothing, no questions so far from the chat box.
Can we go to first spotter?
So there's a spotter now. I think audience can respond in the chat box.
Okay. The spotter number 1, 30-year-old retroviral positive male patient with right cervical lymphadenopathy. This is the histopathological histomorphology of the lymph node, and this is under the fluorescent microscope.
Dr. Manish, Dr. Tejal, Dr. Anusha, they say it's cryptococcal trochosis.
Yeah, it is a cryptococcal lymphadenitis, mainly seen in the retroviral immunocompromised individuals. Usually we see in the lung, and dissemination can also occur in the lymph node. So it is a cryptococcal lymphadenitis. Thank you.
Shall we move to case number 2? Case number 2 will be presented by Dr. Surabhi from Kasturba Medical College, Bangalore. Dr. Surabhi, you may present now.
Yes, sir. Can I audible?
Yes, you are audible. You are the presenter now. Please take over.
Good afternoon, everyone. This is Surabhi Patel from Kasturba Medical College, Bangalore. I will be presenting case 2. With a history provided, a 65-year-old female who underwent hysterectomy. Gross examination of this hysterectomy specimen, uterus measures 13 into 10 into 7 cm, cervical part measures 4 into 1.5 into 1 cm, cut surface of uterus, endometrial lining appears effaced by large gravi tumor measuring 10 into 7 into 8 cm. Cut section is firm with focal whorled appearance and focal yellowish areas. Coming to the microscopy, tumor appears arising from the endometrium. Here we can see that tumor is infiltrating into the myometrium. This tumor is extending up to the full thickness of the myometrium, reaching up to the ink surface. Tumor made up of predominantly sheaths, fascicles, and in perivascular arrangement. On higher power, we can appreciate these long fascicles with a tumor in sheaths and perivascular arrangement of the tumor cells. Coming to the morphology of these tumor cells, this tumor is highly pleomorphic, composed of polygonal and elongated spindled cells. These polygonal cells have a dense eosinophilic cytoplasm, eccentrically located nuclei, prominent nucleolus. They appear as a rhabdoid cell. Also, with these cells, strep cells are present. On higher power view, we appreciate the strep cells with occasional cells showing cross striations. Along with these cells, two multinucleated tumor giant cells are noted. with interspersed endometrial glands lined by atypical cells. Few senile atrophic and cystically dilated endometrial glands are also noted. Invasion, areas of necrosis, lymphocytic infiltration, and a few mitotic figures are noted. Coming to the cervix, ecto and endocervix, both the cervix are involved by. Here we can see the tumor infiltration into the cervix. On basis of this histomorphology and age of the patient, as a 65-year-old lady, my differential diagnoses are carcinosarcoma with heterologous mesenchymal component, pleomorphic rhabdomyosarcoma, leiomyosarcoma with rhabdoid differentiation, and malignant pecoma. To call it carcinosarcoma, extensive examination of all the sections are required to look for malignant epithelial component. Also on age of the patient, arrangement and the morphology of the cells, pleomorphic rhabdomyosarcoma and leiomyosarcoma with rhabdoid differentiation can be considered. Lastly, malignant pecoma can be considered where we can see the perivascular arrangement and rhabdoid morphology has been described. To confirm the diagnosis, immunohistochemistry can be done, in which this mesenchymal myogenin and myo-D1 will highlight the mesenchymal component of the carcinosarcoma, with CK, EMA, ER, and P53 will highlight the epithelial malignant component of the carcinosarcoma to confirm the diagnosis of MMMT. Only this mesenchymal myogenin, myo-D1, and desmin are positive. Along with PEG7, we can confirm the diagnosis, that is pleomorphic rhabdomyosarcoma. With these three markers, if SMA is positive, leiomyosarcoma with rhabdoid differentiation can be ruled out. And to rule out pecoma, we can do HMB45 and Milan A. Thank you.
Dr. Surabhi, can I ask you one question? I'm Dr. Jayram here.
Yes, sir.
In a resource poor setting, if you need to pick out only one or maximum of two markers, which ones would you look for?
Sir, for the rhabdoid differentiation, we can do the myogenin. And to confirm the carcinosarcoma, cytokeratin for epithelial component.
Are the cross striations not enough?
Cross striations are there in few cells, sir.
Okay. But will cross striations be seen in any other cell other than a rhabdoid or rhabdomyosarcoma or a skeletal muscle?
Sir, in strep cells, we can see the cross striations.
Okay. So my point here is, how much importance do we give to light microscopy? Do we straight away, because whether they're required or not? Anyway, your presentation was good, Surabhi.
Yes, sir.
Now we have Dr. Raj presenting case number 2.
Good afternoon, everyone. I'll be presenting case number 2. First of all, the clinical history that we have. It was a 65-year-old female hysterectomy specimen we received in the lab, and there were no additional clinical details provided with the specimen. This is a gross picture of the specimen that we received. As you can see, the uterus is quite bulky, while the cervix and attached bilateral adnexa were unremarkable. When we received the specimen, the tissue was unfixed. However, when we cut the specimen, we saw a large polypoidal mass in the endometrial cavity, effacing the endometrium. After fixation, we saw the mass was white, having a smooth to whorled appearance with areas of necrosis. The cervix and bilateral adnexa were unremarkable. Coming to microscopy, as you can see, the tumor is arranged, has a loop pattern which represents its orientation, and the tumor was infiltrating the myometrium. This is a low-power picture of the same. The tumor cells were arranged in interlacing fascicle sheets. Haphazard orientation was there and was composed predominantly of the large pleomorphic cells. This is a high-power view of the cells. The cells were large, pleomorphic, having abundant, dense, eosinophilic, stringy kind of cytoplasm and pleomorphic nuclei with strap cells showing some cross striations. These cross striations were better visible in oil emulsion field. The cross striations present in the strap cells. Scattered binucleated to multinucleated cells were present. Mitosis were seen amounting to 2 to 3 per ton high power field. The cervix showed involvement by the tumor and showed areas of around the spindle cells with increased mitosis. Areas of necrosis and infarction were seen. Occasionally, we found entrapped endometrial gland which was benign in nature. This is the endometrial gland. Based on the responses that we received and the differentials that we had, I've compiled them all together and I'll deal with them below onwards. First of all, pecoma, we ruled out pecoma because the cells were, although it was a kind of perivascular arrangement at some areas, but the cells were not having a clear cytoplasmic appearance. Coming on to second, high-grade endometrial stromal sarcoma. Endometrial stromal sarcoma, there was focal stromal component in the tumor, but predominantly it was large pleomorphic cells, and they were absent of blue cells, stromal cells. Leiomyosarcoma, both epithelial and rhabdovariant, we ruled out due to presence of the cross striations in the strap cells, which are absent in leiomyosarcoma. Coming to uterine rhabdomyosarcoma with adenoma malignum, this cannot be the differential because the malignant glandular component is not present. Now, if I go to recollect all the positive points to come to final diagnosis, it was an infiltrating tumor. Secondly, the tumor was composed predominantly of large pleomorphic cells with cross striations in the strap cells. The focal stromal component was there, which was not predominant. And lastly, there was an absence of malignant glandular component. Occasionally, benign endometrial gland was seen, but we felt it was a kind of trapped endometrial tissue because the single gland was surrounded by the tumor cell. So the first differential that we considered was primary pleomorphic rhabdomyosarcoma, and the second that we considered was malignant mixed Mullerian tumor or carcinosarcoma with extensive heterologous differentiation. We chose primary pleomorphic rhabdomyosarcoma over malignant mixed Mullerian tumor despite being a rare tumor because of the absence of the glandular component that was malignant. We couldn't find any malignant glandular component, so we kept primary pleomorphic rhabdomyosarcoma on our first place, priority basis. So to confirm the different diagnosis, we did myogenin for this specimen, and we found around 50 to 60% of tumor cells were positive for myogenin. So the final diagnosis that we gave was first primary pleomorphic rhabdomyosarcoma, followed by second malignant mixed Mullerian tumor with carcinosarcoma with extensive heterologous differentiation. Pure rhabdomyosarcomas occurring in uterus of adults are very rare and have a poor prognosis. This tumor type usually occurs in infancy or childhood and is referred to as sarcoma guttaria or embryonal. most commonly involving the vagina or cervix. In adults, it is usually encountered as a heterologous component of a mixed malignant mesodermal tumor. Usually, rhabdomyosarcoma occurs in the setting of a biphasic tumor, that is carcinosarcoma we call it. Pure tumors are extremely rare, and less than 80% cases have been reported till now. Majority that we see around component that we see is 67% is pleomorphic rhabdomyosarcoma and 40% is abdominal rhabdomyosarcoma. If rhabdomyosarcoma occurs in the female genital tract, it is more common in cervix, followed by corpus, uterine corpus. Thank you, everyone. Any questions? Any questions, chat box?
We'll go ahead with this quarter. 30-year-old female presented with oral and upper limb vesicles. They had oral erosion with upper limb vesicles.
Please come close to the mic. Your audio is feeble.
This was a 30-year-old female who presented with oral vesicles and upper limb lesions. This is the light microscopic image. This is the other light microscopic image of the same case. This is the immunofluorescence of the same case.
Any respond in chat box? Dr. Ranjana says pemphigus vulgaris. Dr. Minesh says Darius disease. Anybody else? Dr. Akina says pemphigus. All right. Dr. Avani is also for pemphigus vulgaris.
It is an intraepidermal blister with an fishnet pattern on iron, so it's more in favor of a pemphigus vulgaris. Can we go to the next case?
Yes.
We
and
have
there are few questions for the previous one.
Yeah.
Dr. Nathan wants to know why can't it be adenosarcoma, sorry. And his other question is why can't it be pleomorphic undifferentiated stromal sarcoma, which doesn't need stromal differentiation? That's Dr. Nathan from Mysore.
What was the first question? Why can't it be?
Adenosarcoma.
We don't have any glandular element. We did an extensive sampling. We have not found any malignant glands apart from one single gland which was appearing benign. So we are not in favor of an adenocarcinoma.
The other DD that he was wondering was a pleomorphic undifferentiated stromal sarcoma.
Pleomorphic undifferentiated stromal sarcoma, we are seeing so many of rhabdoid cells which have cross striations. There is a lot of rhabdoid cells, which is more than 50% of our sections. So we are favoring more in terms of a rhabdomyosarcoma rather than a undifferentiated sarcoma. Maybe undifferentiated will be more of spindle cells which will not have rhabdoid differentiation.
Okay. Could it be malignant? Dr. Ranjana Ranade wants to know, could it be malignant adult rhabdoid tumor?
Malignant
rhabdoid.
I feel malignant rhabdoid tumor has more of round cells rather than pleomorphic strap cells. It is more of a round cell morphology, not a pleomorphic spindle cells. What you are seeing, rhabdoid cells, more of strap cells.
All right. Shall we move to case number 3? Dr. Pooja, you can take over. You are the presenter now and begin your presentation. Dr. Pooja?
Yes, sir. Yes, I'm sharing. Sir, is the screen visible?
Not yet. It's still coming up. Yeah, it's up now. Just share your screen. Make it full screen. Open a pop. Yeah, make it full screen.
Yes, sir.
Go ahead.
Good afternoon, everyone. Myself, Dr. Pooja from IMS Ballari. I'll be presenting case number 3. So the history provided was 35 years old 35 years old female patient with anterior mediastinal mass. The serum beta and HCG AFP are normal. Received multiple whitish tissue cores, largest measuring 1.5 centimeter in length. So this is a whole mount view showing the 4 tissue bits. This is a scanner view and the low power view showing the tumor cells which are diffusely arranged in sheets. And at many places we can also see the tumor cells which are arranged in lobules separated by thick fibrous bands separating, which are widely separating these lobules. And at many places we can also see these tumor cells are arranged in cords. And this is the same high power view showing the tumor cell arrangement in cords separated by in a background of a fibrous sclerous stroma. These tumor cells are large pleomorphic with abundant dense granular eosinophilic cytoplasm. The nucleus is pleomorphic, hyperchromatic with irregular nuclear membrane and inconspicuous nucleoli. We can also see few intercellular bridges at places. And we can also see the many nerve bundles surrounding which we can see the tumor cells. This is the same high power view showing the nerve bundle surrounding which we can see the tumor cells. And this is a foci showing the necrosis surrounding which there are many tumor cells. The stroma is dense and fibrous sclerous with scattered lymphocytes and many nerve bundles. So to summarize, the cells are arranged in diffusely in sheets, widely separated by fibrous bands, and these are also arranged in cords. So these cells are pleomorphic, polygonal with dense granular eosinophilic cytoplasm. The nucleus is hyperchromatic, pleomorphic with irregular nuclear membrane and inconspicuous nucleoli. We can also see the intercellular bridges, perineural invasion, focal area of necrosis, and many nerve bundles in this stroma. So based on the morphological features, I have arrived at 3 differential diagnosis. That is, the first one is thymic carcinoma, non-keratinizing squamous cell carcinoma, type B3 thymoma, nut carcinoma with rhabdoid features. So I would like to do the IHC markers to rule out these 3. So the first with the thymoma, these are positive for the pankeratin CK90 and CK19 5/6 and cytokeratin 7 P63. But these and thymic carcinomas are also positive for these thymoma markers. So the main differentiating features are CD5 and CD117. And to differentiate the nut carcinoma with rhabdoid features, I would like to do NEMA, keratin, CAM 5.2 and vimentin. And these nut carcinomas are negative for CD5. So based on the histomorphological features, that is the infiltrative growth pattern, lobules separated by fibrous band, pleomorphic and hyperchromatic cells, intercellular bridges, perineural invasion, and focal necrotic areas, my provisional diagnosis is more in favor of thymic carcinoma, non-keratinizing squamous cell carcinoma. Thank you.
That was a quick fire presentation. Dr. Akshat, over to you. Audience may share their diagnosis in the chat box. Rashid, you're not audible.
I'm audible now?
Go ahead, go ahead, go ahead.
Yeah. Okay, that indeed was a very good presentation by Dr. Pooja. Okay, coming to the microscopy, before that, yeah, this is the case 3, 35-year-old lady. She had come to the clinic with symptoms of COVID, though COVID was negative. On X-ray and mass was detected, okay, in the mediastinal region. And X-ray was also done, CT scan was done, followed by which we had received these multiple linear codes. So in all, we had received multiple linear codes, largest measuring about 1.5 centimeters in length. And as you see on the low power, you can see that these pores are, they contain these tumor cells which are present in sheets, nests, pods, and also in a trabecular pattern. As you go on hyper view, here you can view that these cells, okay, they're almost oval in shape, oval to polygonal shaped cells, okay, having this nice round to oval hyperchromatic nucleus, and most of these nucleus is present eccentrically, okay. And when we saw the entire slide, there were hardly any mitotic figures which were visible. And throughout, there was no presence of any keratinization, nor there was any gross evidence of intercellular bridges. Now, when I go on hyper view here in this particular area, which is showing sheets of these cells, can anyone tell me what do these cells resemble like? Oval cells, eccentric nucleus, and few of the cells showing the presence of nice intracytoplasmic lumina. Here you can see one big lumina here. Again, one more here. Even if I show in this foci, cells are almost, most of the cells, oval cells having eccentric shaped nuclei, hyperchromatic nucleus, almost resembling like a signet ring cells. So the entire course was showing presence of these signet ring cells in varied patterns. So similar presence of similar cells. Another picture showing cells have intercytoplasmic lumina. So at this juncture, okay, so the differential diagnosis what we had received was the most common response was metastasis to the thymus, followed by sclerotic thymoma, epithelioid variant of solitary fibrous tumor, type B3 thymoma, thymic squamous cell carcinoma, a neuroendocrine tumor, small cell carcinoma, nut with rhabdoid features, and epithelioid hemangioendothelioma. So for us, based upon the microscopy findings what we had seen, the differentials what we were thinking was one, yes, metastasis to the thymus, and it could be a thymoma, but a higher grade of thymoma, maybe a type B3 thymoma or a thymic squamous cell carcinoma on microscopic features. So with these findings, we went ahead with the IHC. Initial panel we did to rule out metastasis to the thymus, CK7 and CK20, both were negative. Then since there was presence of these signet ring cells and intracytoplasmic lumina, we thought it could be metastasis from a breast, that is lobular carcinoma of the breast. So we did the IHC with hemoglobin, which showed some non-specific staining. To confirm it, we did an ER. ER was also negative. So it kind of rules out a metastasis from the breast. So then before going ahead with further markers, we still wanted to rule out if it is an adenocarcinoma. We did simple stains of PAS and mucicarmine. Both were negative for presence of these vacuoles in the cytoplasm. Then when you compare the CK20 profile, what we had got in this case, the most common tumors with this profile are hepatocellular carcinomas, the renal cell carcinomas, prostate carcinomas, squamous cell carcinomas, and of the lung and the head and neck. But the microscopy did not fit into an hepatocellular carcinoma or renal cell carcinoma. So the only probability what could be still present is a squamous cell carcinoma. So to rule out this, we did an IHC with P40. And as you can all see, P40 was also negative in this given particular case. So at this level, your thymic squamous cell carcinomas or your metastasis to the thymus from a squamous cell carcinoma elsewhere, that is from the lung or from the digestive tract, is kind of ruled out. Then there was one DD of epithelioid hemangioendothelioma. So we had a marker of CD34 and 31, both were negative in this case. So that kind of ruled out an epithelioid hemangioendothelioma. CD117 was done in this case, keeping in mind thymic carcinomas, because almost they say 90 to 98% of thymic carcinomas are positive for CD117. So as evident on the screen, CD117 was also negative. So a thymic carcinoma was ruled out, a thymic squamous cell carcinoma was ruled out, METS was ruled out, and a vascular tumor was also ruled out. So then we were still thinking what it could be. We did a plain pan-CK. To your left, a plain pan-CK was diffusely positive in these cells, telling that it is an epithelial tumor present in the mediastinum. And the second IHC, what we did was PAX8. PAX8 is most commonly positive, 100% of times positive in cases of a thymoma. So you're dealing with a thymic neoplasm. But it kind of doesn't fit into the actual WHO classification of a thymoma, wherein WHO classifies thymoma as type A, type AB, B1, B2, B3, and C. The morphology didn't fit into any of the typical WHO classification of a thymoma. At the same time, we had got a PET scan findings wherein it was 6.9 into 6.4 into 5 centimeter metabolic active lobulated anterior mediastinal mass, wherein they suggested that it is a primary thymic neoplasms and showing extensions into the adjacent soft tissue areas. So then we compared the IHC what we had got. CK was diffusely positive in our case. P63, P40 was negative in this case. PAX8 was diffusely positive in our case. CD117 was negative. CK7 was negative. CD5 we did not do it. So in the end, to summarize it, we call it as thymoma with signet ring-like cells. Discussion, it appears to be of low grade. The tumor is composed entirely of epithelial cells with signet ring morphology and sparse lymphocytes. As in even in our tumor, the presence of lymphocytes was very sparse. There were hardly few pockets of lymphocytes seen in the sections. And the immunoprofile was also same as what we had got. They are reactive for pan-CK, CAM 5.2, the negative for CD117, CD5. The closest differentials, what you could think is a yolk sac tumor, vascular tumors, metastatic carcinomas, and another rare variant, signet ring cell variant of thymic carcinomas. This was the reference article, and there are very few cases which have been reported. And this case also had similar findings of what we had got in our case. Thank you. Wait for some questions. There's a question, why not sclerosing thymoma? Yes, it could be a sclerosing thymoma, but how could you explain the presence of diffuse sheets of these signet ring cells? It is almost occupying the entire tumor, though there is presence of a good amount of fibroblastic proliferation, sclerosis around the tumor cells. So based upon the presence of the kind of morphology of cells, we called it as thymoma with signet ring-like cells.
Dr. Minesh Gandhi wants to know whether it's B3.
No, again, B3, we couldn't think of B3 because B3 will again have these pleomorphic appearing epithelial cells, lot of lymphocytes along with them, and the mitotic figure was also very low. So we didn't think of presence of this B3 thymoma, and also sometimes they are positive for P63. Okay. We'll go ahead with the spotter.
Yes, please.
Yeah. Okay. Can you identify what organ it is and what am I holding in the hand on the left side?
Kindly respond on the chat box. Identify the organ.
Okay, there's no response. Okay, I think it will be much easier if I show the microscopy. To the left, you're seeing presence of these nice tubules containing eosinophilic material, atrophic tubules. The sclerotic structures are seen to your left. Okay, okay, I think there's no response. Okay, this is nothing but a nephrectomy non-functioning specimen. Okay, and to the left, you can see I'm holding a staghorn calculi, which has caused chronic pyelonephritis, and one very rare finding which can be seen associated with chronic irritation is extensive intestinal metaplasia. So this was a case of extensive intestinal metaplasia of the renal pelvis, which is caused by a renal calculi and should not be confused with an intestinal adenocarcinoma.
Shall we move to case number 4?
Yes, thank you.
Dr. Reshma, kindly present it.
Is it visible, sir? Am I audible?
Yes, you are. Please go ahead.
Okay. Good afternoon, everyone. I'm Dr. Reshma, PG resident of JSS Medical College. I'll be presenting case number 4. The given history was 63-year female undergone total thyroidectomy, query carcinoma thyroid, query goiter. On examination, the right lobe measured 6 into 3.5 into 3.5 centimeter. External surface appears nodular. Cut surface, a partly circumscribed nodule measuring 4 into 3 into 3 centimeter was noted. Moving on to the microscopy, under the low power, we could see a tumor which was arranged in papillary pattern. This is a high power view of the papillae. It was also arranged in micropapillary pattern, which lacked a fibrovascular core and follicular pattern. Discohesive cell clusters with nuclei atypia at foci was seen, which had reversed polarity with prominent apical snouting. Few cells showed nuclear clearing and nuclear grooving with abundant and voluminous eosinophilic cytoplasm. Some of them showed prominent nucleoli. Nuclear crowding is noted. Discohesive cell clusters with secretions were seen. Also seen by areas with variably sized colloid filled microfollicles and macrofollicles with cystic changes. Areas with lymphoid aggregates and Hürthl cell changes were noted. Calcifications were present. Foci of colloid-laden macrophages, lymphocytes, and areas of hemorrhage seen. A section of normal parathyroid is seen. Summarizing my microscopic features, sections from thyroid displays a tumor with papillary, micropapillary, and follicular pattern. Discohesive cell clusters with nuclear atypia seen. Few showing nuclear clearing and grooving, some having prominent nucleoli with abundant eosinophilic cytoplasm. Prominent apical snouting and areas of nuclear crowding is present. Also seen are areas with varying size colloid filled micro and macro follicles with Hürthl cell changes, many lymphoid aggregates, hemocentrin-laden macrophages, and calcifications noted. A section of normal parathyroid is seen. As hobnailing pattern was seen more than 30%, my probable diagnosis would be hobnail variant of papillary carcinoma thyroid with Hashimoto's thyroiditis. Thank you. Have Dr. Sunita presented last case. First, Dr.
Dr. Reshma, you did a good, excellent presentation covering almost all the points. But see the one, what we have received is already gross is mentioned by you. We receive a total thyroidectomy specimen with a right lobe enlargement 6/3. So I'm concentrating mainly on the nodule which is on the right lobe. This is the one area where you are seeing the follicles of the varying sizes filled with a colloid and the lymphoid infiltrate. Here you are seeing the nodules of the varying sizes, but when you go to that, there is a one minute. This is the gross one. There is a right side nodule is enlarged and left lobe looks normal. This is the cut section of the thyroid where you can see the ill-circumscribed nodule grossly with multiple whitish areas outside that one. See, when we go on to the nodule, you are seeing well-defined capsule. There are the nodules of the varying sizes and shapes filled with the follicles of the varying size. But if you see the nodule, this is a purely encapsulated nodule with thickened fibrous capsule. And as you mentioned, these nodules are lined by epithelium having the vesicular nuclei with a prominent nucleoli. These are the closely packed nodules. As you said, there's a nuclear grooving and pseudostratification, vesicular nuclei with the orphan Annie features. So you are seeing the capsulated neoplasm, capsulated lesion with the follicles of the varying sizes and shapes filled with colloid, and these follicles are lined by the cells having the papillary-like nuclear features. Within the whatever the calcification psammoma bodies, those are there in the outside the capsule section. Within the nodular areas, you are seeing papillary, like see the classical nuclear, vesicular nucleus with a nuclear groove, vesicular with orphan Annie. These are the scalloped colloid. See, at this point, I am just mainly stressing on the encapsulated nodule with the follicles of the varying size, lined by cells having the clearing nuclei with the papillary-like nuclear features. Any other differential in the thought? Anything in the chat box? No. Okay, I'll move off. These are the responses we received. First is a nodular goiter with a secondary hyperplasia. As the second one, again, multinodular goiter with hyperplastic nodules. Correct. It is a multinodular goiter with a hyperplastic nodule is the first differential diagnosis. The second, again, with a papillary carcinoma also, but we can't combine the multinodular goiter with hyperplastic nodule, multinodular goiter with a papillary carcinoma. Hyperplastic nodule is a benign condition, papillary carcinoma is a malignant condition. So we can't put both. And third one is a tall cell columnar variant. Here, the cell length is not, what is the criteria for tall columnar? The length of the cell should be the double size of the width. No, here we are seeing abundant cytoplasm. The length is not that. So we are not dealing with the tall columnar vent of papillary carcinoma and poorly differentiated. So how the poorly differentiated carcinomas looks, the tumor cells should be in sheets, clusters, and sheets, the pleomorphic, no. So we are not. Then follicular variant of papillary carcinoma, yes. We have to put that into the DD because of the follicles are classically lined by papillary nuclear features. So, but how we are deviating from this, I will tell in this discussion. Follicular carcinoma of the thyroid. Follicular carcinoma of the thyroid will be closely packed follicles as I showed, but they won't have the papillary nuclear features. Here the papillary nuclear features are the prominent, we can't disregard that. Then it is a medullary carcinoma. No medullary carcinoma with this type of the fills, it won't fit. So with this, we made a diagnosis of. So I was stressing throughout my lecture, capsule was intact. There was no breach in the capsule. There is no capsular invasion. So this case comes under non-invasive follicular thyroid neoplasm with papillary-like nuclear features, NIFTP. When we go to the WHO classification of the recent 2017, they enclosed one variant called other encapsulated follicular patterns of thyroid. Previously, it was a follicular carcinoma with undetermined malignant potential. No, now this is a new entity in the 2017. One is a follicular tumors of uncertain malignant potential. Okay, there you should see at least some tumor cells sitting in the breech bed, but they don't have the papillary features. The second, well-differentiated tumors of uncertain malignant potential. No, we are stressing tumor. So third, it is a non-invasive follicular thyroid neoplasm with papillary nuclear features. So to diagnose this, it should be, you should see whether it's an encapsulated lesion or an infiltrated lesion. So there are multiple nodules are there which is showing the hyperplastic one. The one which is showing the papillary-like nuclear features are an encapsulated lesion. Whether there is an invasion or non-invasive, in our case, that encapsulated one with the papillary is a non-invasive. So it goes into the favor of non-invasive follicular thyroid tumor with papillary-like nuclear features. These tumors are previously known as non-invasive encapsulated follicular variant of papillary carcinoma. That's what few people will receive the responses like a follicular variant. But at present, suggested to rename this lesion as NIFTP based on international multi-concept study showing the indolent behavior. What's the indolent behavior? There won't be a metastasis, lack of metastasis and lack of recurrence. It's estimated up to 4.4 to 9.1% of the all papillary carcinomas. The rate of occurrence is 8 times lower in our Asian country population compared to Western Europe and American population. But how we are going to define? The article WHO has defined a very good inclusion criteria and exclusion criteria. In the inclusion criteria, again, major and very important feature is the encapsulation. Second, follicular growth pattern with less than 1% of the papillae. And we saw the papillae. Some Reshma mentioned nicely, it is a pseudo papillae without a fibrovascular core. It is a pseudo papillae, so it's 1%. There is no summoma bodies and nuclear features of the papillary carcinoma score 2 of 3. We have a nuclear clearing, orphan Annie features, pseudo stratification, and nuclear molding and overlapping. What will be a minor features? Dark colloid. We had that in our case. Irregular shaped follicles and sprinkling sign. Sprinkling sign in some cases, this papillary-like features, it will be like a sprinkle, like what we see like a star sky up like that. These papillary features will give a sprinkling appearance. And the one which you showed that giant cell is a multi-nucleated giant cells within the stroma, which is like a, what is the detached cells. What is the exclusion criteria here? Any capsular or vascular invasion, you can't name it as NIFTP. If you see true summoma structures in more than 1% of the tumor, you can't necrosis, again exclusion, and morphological features of any other papillary thyroid carcinoma, means tall cell, columnar cell, whatever, so many other variants. If you see any tall, columnar and everything along with these features, you can't call it as NIFTP. So this is initially the diagnostic criteria for NIFTP. This is the primary. But now at present, the diagnosis has moved to the mutation study. Because this follicular tumor, this we are called, though it is a papillary-like nuclei, we are calling it because it is not showing the BRAF mutation. BRAF, which is a classical of the papillary carcinoma, but this is presenting as a follicular with a RAS mutations. So it is in between a follicular adenoma and a follicular carcinoma with a RAS-like mutation. So we have behavior like a follicular. And what should be the diagnosis? The diagnosis of NIFTP only made after histological examination of the entire tumor. You should give the sampling, you should do the sampling of the entire tumor of the capsulation during the surgery. And strictly defined inclusion and exclusion criteria is very important. If you come to the prognosis, it's excellent prognosis with indolent curves. Already I told there won't be a lack of metastasis and recurrence, and believe that the tumor excision is sufficient and no extended surgeries or ablation therapy is needed. That's my references. Any other doubts? So nowadays, now we have to rethink if any encapsulated lesion with a hyperplasia of the follicle with a papillary, we should not jump to the follicular variant of papillary. You should search entirely for a capsular invasion. Okay, can we move to the spotter? Yeah. 12-year-old boy with itchy brown skin macules. This is the history given to us. See, this is the section from the skin biopsy. Epidermis with a dermis. There are some cells in the cards and sheets. Go that. These cells are, I am only giving the description. I don't know how. It's a round to oval with abundant cytoplasm. And cells are monotonous in appearance. One special stain. This is a toluidine blue stain. It can give you the hint. I'll go back to H&D slide.
Audience, any responses for this spotter? Dr. Anusha says mastocytosis. Dr. Manish Gandhi says cutaneous mastocytosis. Anybody else? Same with Dr. Chaitra T. Most of them say cutaneous mastocytosis now.
Yeah, very good. It is a case of cutaneous mastocytosis. Thank you.
Right, we'll move to case number 5, Dr. Deepthi.
Yes,
Kindly take over.
Am I audible, sir?
Yes, you are. Let's wait for your screen to come up first. Make it full screen. Please go ahead.
Good afternoon, everyone. My case is case number 5. History given is 71-year-old man with persistent leukocytosis and massive splenomegaly. Next question is cell counter with findings. According to the cell counters, RBCs and RBC are in normal limits with platelet count in normal limit. WBC shows increased count with neutrophilia and shift to left. So my answer is normocytic normochromic blood picture with neutrophilic leukocytosis with shift to left. Next question is list out a deviation in normal scatter. The deviation seen are leukocytosis with shift to left, monocytosis, eosinophilia, basophilia, and anarbesis. Next, differential diagnosis with ever findings. I like to give myeloproliferative neoplasm, which could be chronic myeloid leukemia or chronic neutrophilic leukemia. Next, peripheral smear is given. Peripheral smear shows mild anisopoikilocytosis with teardrop cells, polychromatophils, and NRBCs. WBCs are mostly segmented neutrophils and band forms, and platelets are arranged discretely. This is a neutrophil type shown, predominantly shows mature neutrophils and band forms. And in this, atypical lymphocytes are seen in blastoid and monocytoid type with eosinophil precursors and a few mature eosinophils. Coming to marrow aspirate findings, these are the marrow pictures given, which include predominantly mature neutrophils and few band forms and myelocytes. So erythropoiesis shows few late normoblasts. Myelopoiesis shows predominantly mature neutrophils, few band form, occasional myelocytes and eosinophils, and megakaryopoiesis shows few immature forms. Coming to marrow trophine biopsy, this was the picture given. It shows both hyper and hypocellular area. These areas of fibrosis noted. Next, these are the megakaryocytes, which shows change in topography with clustering of megakaryocytes, and there's a nuclear size variation. Another area of fibrosis, this area shows mature neutrophils and fibrosis. Reticulin stain was given. In this, there's a dense reticulin deposition is seen. According to WHO 2016 criteria, I like to give grade 2, which shows diffuse and dense increase in reticulin with extensive intersection, occasionally with focal bundles of thick collagen consistent with collagen and or focal osteosclerosis. With ever findings, my differential diagnoses are myeloproliferative neoplasm, maybe because of primary myelofibrosis due to overt myelofibrosis and secondary myelofibrosis because of chronic myeloid leukemia or chronic neutrophilic leukemia. Next question is further tests to be done. First, I like to do mesenteric stain to grade the collagen deposition. Next is to test for BCR-ABL to rule out CML or CML positive, BCR-ABL negative positive. If it is negative, I like to do JAK2, CALR or MPL mutation. And next, test CSF 3RT6181. Though CNL is rare to go for fibrosis, but still need to rule out CNL going for fibrosis. Thank you. Hello.
Just a minute.
Dr. Dilti. Over to Dr. Pradeep.
Yeah.
Hello.
Yeah.
Yes.
Thank you. That was a good presentation.
Dr. Pradeep, kindly make it full screen. Go to display settings.
Yeah, just a minute.
Kindly share again.
Yeah, is it fine now?
Nope. You stop sharing actually.
Just a minute.
Yeah.
It's visible?
Yeah, perfect. Go ahead.
Yeah, so thanks. That was a good presentation. So basically, when we gave this case, we just needed more of the approach rather than the diagnosis, because a leukocytosis, that means neutrophilic leukocytosis, is a very common thing we come across in a routine hematology reporting. So this was a case where is a 71-year-old gentleman with persistent leukocytosis and massive splenomegaly. So when we come to the cell counter plot, like we asked the question of what what are the findings could be. So most of them told it's neutrophilic leukocytosis and few told with left shift. Now then the answer we were expecting was yes, neutrophilic leukocytosis, but left shift is quite minimal. I'll just show you in the further slides how it is. So then we also had given the normal scatter to compare with the present case, where in the present case you can see that there is that neutrophils which are predominant, but absolutely the number of basophils are not as much you expect. So the responses we received were leukocytosis, shift lefts, NRBCs and basophilia, but this was the actual thing where there is no basophilia and left shift is dominant. So this is a slide where I just wanted to show you where this is the left shift which is completely prominent. So if you can see the number of events here to this, it's almost like 1:2 ratio. So the left shift is not at all prominent. Probably you would get in a DC of about 3% or 4%. And then these are the basophils where the events are hardly any in this. So comparing with the first thing, that neutrophilic leukocytosis, a minimal left shift and no basophilia. This is where we are going now. So with that, we had asked what's the differentials you want to consider, and these were the responses we received, where most of them told it's a myeloproliferative neoplasm, few told it's leukemoid, one response of MDS-MPN and one response of leukoerythroblastic. We'll rule out each of these as we go through. So the answer we were looking was just a broad spectrum at this point. We didn't want the complete diagnosis. Basically, we wanted you to say it's a myeloproliferative neoplasm. And features that had to be considered was it's a persistent leukocytosis that rules out a leukemoid reaction, and splenomegaly being there defines it's a MPN. Now, in the peripheral smear findings, the one thing which we wanted you to pick was it's a neutrophilia predominantly. There's no doubt, but there are these cells which have very abnormal segmentations, just like this, where if at all a normal segmentation would be something like where you don't lift the pen till you draw all the lobes, but here you have so many other cells where the lobation is so very haphazard, and that is an indication that it's a myeloproliferative neoplasm. But these kind of cells you also do get in cases of a marrow infiltrative pathology and even MDS, but this is what you can actually observe in most of your MPNs. CMLs are very rampant everywhere, so you can actually start observing such features of neutrophil segmentation to see you have a clue for myeloproliferative neoplasm. And as you can see, the other cells, hardly there's any left shift. So we wanted you to look at everything integrated. So when at the cell counter, when you thought it's a left shift, and on this morphology, there's no left shift, and in the morphology, it's evident that there's no basophilia. So, and in the peripheral blood picture of the RBCs, we didn't find any of the teardrop cells with the picture given. Probably very occasional ones, but hardly any. So we are speaking about, again, neutrophilic leukocytosis, very minimal left shift and no basophilia. So what we wanted you to see was the same thing which I explained, neutrophil abnormal segmentation. So we had a marrow aspirate for this, which was very hemodilute, and the responses received were with predominance of band forms and segmented forms. So here, when we come back, there's hardly any left shift, even in the aspirate. So then when we come to the aspirate picture, there were increased karyocytes, as you can see, but the staining is bad. Please, we're sorry for that. But then as we go through again, what is very much catchy is this abnormal segmentation again. And it's all filled with more of the mature cells and hardly any left shifted cells. And here one more again where the lobation is very, segmentation is very abnormal. So very similar findings with the aspirate, and with the trephine, actually the rest of it was kind of crushed artifact. So that actually doesn't qualify for your examination. This was the only viable space we had. And features again towards a MPN. So The reticulin staining at this particular cellular area, it was not increased as such. So going by complete picture as of now, this was the final question we asked, where integrating the clinical picture and morphology, what would you consider? So PMF over PMF, it's completely ruled out because there you expect more of cytopenias, and the reticulin should have been more increased in the cellulars, the only space which we had. And the secondary myelofibrosis, CML, is completely ruled out as a, because there is no bulge in the myelocyte region, or there's no basophilia as such. So, but I'll just go to the final discussion, where final answer, what we were expecting was it's a myeloproliferative neoplasm. That's a broad spectrum we wanted you to come to, and a possible chronic neutrophilic leukemia. So we have just listed out why it is not others. A CML is ruled out because there's no basophilia and there's no prominent left shift. There's no significant dysbiosis or left shift or monocytosis or blast, because those all would come under MDS MPN, including your reticular CML. And PMF, because there's no leukoerythroblastosis or fibrosis. And then this is one of the articles where they mention completely about how to diagnose a PMF and ET. It's a very good article if you want to start diagnosing the MPNs. And then the last question we asked was further tests to be requested, and most of them were spot on. This is the thing we wanted to know. So we actually followed up this patient, and BCR-ABL was negative, CSF-3R was negative, but JAK2 was positive, indicating that it's still a clonal proliferation. And presently the patient is on ruxolitinib and his counts have come down to 12,000. And even his spleen has been regressing in size. So that's from our side. Any questions?
Thank you, Dr. Pradeep. That was crystal clear. We have no questions so far. Is there a spotter now coming up?
Just a minute.
Or just we move to the last case?
Yeah, can we move to the last case? We'll put the spotters together.
Dr. Anusha, you are next.
Yes.
Last case for the day.
Sir, am I audible, sir?
Dr. Anusha, could you please just share your PowerPoint window? I believe you shared your screen. So just close. Yeah. I'll just take back controls from you. Yeah. Now you share again. Share this time. Share only the PowerPoint window.
Yes. So is it visible now?
Just a second. Yes, it's visible. Make it full screen and go ahead.
Yes. Good evening. I'm Dr. Anusha from KMIO. I'll be presenting case number 6 with a history of 30-year-old male patient with anemia, icterus, episode of pain abdomen and bone pain. With the history, we can think of an hemolytic anemia, probably with vaso-occlusive crisis. With a vaso-occlusive crisis, and I think it is of mild to moderate severity because he has only 6 transfusions till date. On examination of the peripheral smear of the, the Coulter data of the patient shows that the hemoglobin, hematocrit and the RBC indices are of low normal, and there is increased RDW indicating that there is anisocytosis. WBC are normal in number and distribution. However, in the scattergram, we see this population of cell below the lymphocyte. In this particular case, it might be the NRBCs that are depicted in the WNR curve. And platelets are normal with a slight increase in the PCT. The peripheral smear of the patient is given to us. There is no lymphocyte to compare. However, there are few microcytes and hypochromic RBC exhibiting moderate anisopoikilocytosis. Poikilocytes consisting of target cells, boat-shaped cells, few having pointed ends, and polychromatophils. On examining the nucleated cells, here the background RBC, few of them shows basophilic stippling, and as seen in the Coulter reading, there are NRBC in the peripheral smear. WBCs are normal in maturation. However, few reactive lymphocytes and vacuolations are noted in the granulocytic series. Hemoglobin electrophoresis of the patient is given to us, which shows that there is elevated HbS, which is an abnormal hemoglobin of 71%, and markedly reduced normal HbA, and HbF and HbA2 are also elevated. With this finding of anisopoikilocytes showing target cell, crescent-shaped RBC, which could be a sickle cell, and presence of NRBCs, and hemoglobin electrophoresis showing marked increase in the HbS and HbA2 elevated, I think it is a sickle cell disease, probably a heterozygous sickle cell beta thalassemia. To confirm the pattern of inheritance, family study is advised. So mother's Coulter data is given to us, where it shows that she is having microcytic hypochromic RBC with increased RDW. When MI index was calculated, it was 14.05, possibly indicating an iron deficiency anemia as indicated by the flag. And also the RBC histogram shows the same. The WNR graph scattergram doesn't show the presence of NRBC, and the reticulocyte scattergram doesn't show any immature reticulocytes. Platelets are normally in distribution. However, there is in the peripheral smear, there is no lymphocytes to compare the size, but few hypochromic RBCs are noted and few spirocytes. Hemoglobin electrophoresis of the mother shows reduced HbA and increased HbS. However, HbA is more than HbS, indicating sickle cell trait. But because of the blood picture showing microcytic hypochromic RBC, there can be an underlying IDA which requires further studies. Then Coulter data of the father is also given to us, where the hemoglobin hematocrit RBC count are normal, but he is having microcytic hypochromic RBCs with normal RDW. When MI index was calculated in this case, it was of 11.08, indicating an hemoglobinopathy, probably beta thalassemia minor, which is also indicated by the flag. And in the WNR graph, there are no NRBC noted. Platelets are normal in distribution. On seeing the peripheral smear, there is, on comparing with the size of the lymphocyte, there are microcytic hypochromic RBCs. There are no poikilocytes noted. Hemoglobin electrophoresis shows that there is mild decrease in the HbA of 92.4%. However, there is increased HbA2, that is above the cutoff of 3.2, constituting 5.7%. With this finding, I think the father is having beta thalassemia trait. While putting everything together, mother is of sickle cell trait, father is of beta thalassemia trait. So 25% of the offspring has the tendency of getting sickle cell disease. So this patient is probably having compound heterozygous sickle cell beta thalassemia. Thank you.
That was a good presentation.
Thank you, sir.
Just one question. So when we consider the cell counter findings of mother, you told it seems more of iron deficiency anemia. So would you think you would have gone ahead and still did electrophoresis in this case?
Sir, if we were if we were working up the patient to know for the, family study, I think we would have gone ahead and did an HB. We have to correct, we have to correct the iron deficiency anemia. Then we have to do an HB electrophoresis. We have to do a HB electrophoresis to know the status, whether she is a sickle cell trait or whether she is having a beta thalassemia.
Yeah, but the question is, like, at that point, would you still consider doing, despite anemia, would you still have gone ahead and did the electrophoresis or not?
No, sir. First, I would like to correct the anemia, then.
Oh, I will explain. Thanks. But it's an excellent presentation.
Thank you, sir.
Dr. Pradeep, could you make it full screen?
Yeah. Is it visible?
Not yet. You'll have to go to display settings again and make it swap the presentation. Dr. Rakshit, if you are around.
Yeah. Yeah, visible? Yeah. Am I audible?
Yeah, go ahead, please.
Yeah, okay. So that was an excellent presentation, but okay, let's go ahead with this. So it was a 30-year-old male who has had anemia and 6 transfusions till date and episodes of pain, abdomen and bone pain with icterus. So we had asked what was the differentials you would be considering the clinical picture and the test to be requested. And these were the responses where most of them said it's hemolytic anemia with vaso-occlusive crisis. That was spot on. Never a myeloproliferative neoplasm because we are speaking about icterus and transfusion requiring anemia. So, and then nutritional deficiencies are completely ruled out. So the test to be requested, most of them were right, with they would request for a PS, electrophoresis, bone marrow, definitely no. So these were the responses we would have expected to. So hemolytic anemia and the vaso-occlusive symptoms is what is causing them abdominal pain and bone pain, and that would explain the icterus also because it's hemolytic anemia. So we would request for a CBC, PS, and the electrophoresis. So this was the cell counter data findings, and Dr. Anusha was good with whatever I had to explain. So these are the NR which are sitting, and the only thing for us is we have observed it in quite a few cases where whenever the sickle comes, you always have this kind of unlysed RBC sitting, and that would actually give rise to this gray scatters in the Sysmex platform. So most of them were right that there were NR bases and ghost cells there. And then, so the test to be requested, HB electrophoresis and cycling was again given. With the peripheral smear, as Dr. Anusha showed, there are boat-shaped cells and the target cells. So with the boat-shaped cells, I would think of cycling still. So, and the other NR bases which are there. WBCs we would not actually consider in such cases because that's not giving rise to any pathology as we consider the clinical picture. And this was electrophoresis where this was a pattern. And most of the responses were sickle cell beta thalassemia and one told sickle beta thalassemia trait. So whenever there is 2 genes which are coming like sickle and beta, we would never call it a trait. Only one single mutation is what we call it trait, and they should be asymptomatic. Trait would go in more in favor of asymptomatic, never a disease. So this is a table from Henry which we refer to most of our sickling syndromes. So if you consider this case, the expression is quite moderate. So when you consider only 6 transfusions in 30 years and hardly anything which is actually requiring any occlusive, there was no acute chest syndrome or anything when we digged into this history. So that would give a clinical expression of moderate. Hemoglobin was 11.7, still it might fit in somewhere between sickle beta and homozygous sickle with an alpha deletion. And then MCV of 82, this is where we thought it's more of homozygous sickle disease is there, but there is an alpha mutation. And whenever we have had such cases where there is an alpha deletion, the clinical expression is very, very mild. We'll come to that again. So then HbF was 20.7 and A2 was 4.4. Considering these, because there was not much of microcytosis, our sign-out report was actually a homozygous sickle with an alpha deletion, considering the clinical severity also, which was very much moderate. Now, the question which I asked to Dr. Anusha was like, the reason why I asked was the family screening actually starts when at an antenatal checkup. So at this point, at mother, when she has visited a clinic, if at all she would have had suspected that for MCV of 71 and a hypochromia of 21, RBC of 5.06 is very, very rare in our iron deficiency. So that means there is a hemoglobinopathy sitting in somewhere. And like probably that's when this gynecologist would have probably asked like electrophoresis rather than treating that as iron deficiency. So if at all that case would have picked, we wouldn't have seen the cases which have sickle beta where they have to undergo a lot of transfusions and all that. So with this, the suspicion is still more of hemoglobinopathy rather than iron deficiency. So these were the responses which we received, where most of them told it's a possibility of IDA. But then one of them told it's anemia with erythrocytosis, but we want to translate that onto the clinician, saying they have to request for a electrophoresis. So this is what I spoke about. The discordance is quite much, which you don't expect in iron deficiency. And with the peripheral smear, there are these target cells, microcytic hypochromic cells. But then again, for this particular sickling syndromes, there's a nice table given in DAISY, and most of them told it's a sickle cell trait. But then we learned from one of my colleagues that whenever it's an abnormal hemoglobin which is sitting there, your indices should be always normocytic normochromic. So a sickle cell trait would have had a normocytic normochromic, not a MCV, unless, yes, there is a concurrent iron deficiency. Hello? Yeah. So, but with this case, when you're looking at a thal suspicion with 71 MCV and 5 million RBCs, you would consider that it's a low MCV, basically. So then, when you look at the sickle level, if it was a straightforward trait, it would have been 35 to 38, but this is at 32, sitting somewhere here where it's a sickle trait with an alpha deletion, and that proportion of A is also translated. So this is where you would have picked it's a sickle cell trait with a concurrent alpha globin deletion. But then when we looked at the father thing, most of them were spot on. Again, here if you look at the MCV and the RBC, it's quite discrepant with the MCH. So it's straightforward beta thalassemia trait. So these kind of pattern you usually get in your day-to-day reporting, and if it's a reproductive age group, start mentioning that these people require screening for hemoglobinopathies. So that was the message actually. So considering the final thing, our sign-out report initially was it's a homozygous sickle with an alpha deletion, and alpha is what always gives you the less severity. I'll come to that. So we had actually asked for what are the specific tests you want to do further, and most of them had put as globin chain synthesis and everything, but we wanted a word that you need to look for both alpha and beta. And when we did for this patient, there was a mutant alpha deletion which we found out, and the beta sequencing came out as heterozygous sickle, and there is IBS15. So that actually matches with both the parents, where one parent has a sickle and alpha being there, the other parent has a beta thalassemia. So this is the article where like the answer for the last question, where we asked what's the significance of recognizing such a diagnosis. So whenever you have a sickle with an alpha coming up in a homozygous, or in a case like this, they actually don't require to go for a transplant, because if you put them on hydroxyurea, their lifespan is actually much better. The quality of life is much better. So the take-home message with two cases which we got was, whenever it's leukocytosis, see if it is persistent. Always look for the clinical picture. Always try getting the clinical picture as much as possible and observe the neutrophil morphology. And whenever you are seeing a discordant red cell indices, always think of hemoglobinopathy. Beta, very much common, but there might be even alpha which is sitting, which might give you the clue that you have to screen that particular person for hemoglobinopathy. So that's it. Any questions? Can we go to the spotter?
Yes, please. Please go ahead.
Just a minute. Most of the responses were sickle.
Okay, last two spotters coming up. Audience, be ready to respond to these.
This was a 70-year-old female who presented with postmenopausal bleeding. This was a cervical biopsy. You can see cells arranged in glandular pattern. The same cells on high magnification. What does these cells resemble? Same cells in much higher magnification. If the same cells would be identified in kidney, what would you call it as?
Any response from the audience? Dr. Akina says clear cells.
Yeah.
Anybody else?
Are there clear cells? We also saw areas of squamous differentiation. What is the diagnosis?
Okay, can anybody come up with a diagnosis? Chat box, please.
We went
Audience
back and did
very
an
laid back today. Kindly be active and participate in the spotters. Okay, Dr. Anusha says clear cells. Anybody else? Okay, go ahead, ma'am. Okay, Dr. Neelam says mucoepidermal carcinoma.
of cervix.
Anyone else?
So,
No, go ahead, ma'am.
we signed this as an adenosquamous, clear cell adenosquamous carcinoma of cervix. It's a very rare entity, which is just 1% of the cervical tumors. We did an IHC. This is a P16 HPV IHC, which shows diffuse nuclear and cytoplasmic reactivity. So 90% of these tumors show HPV association. Thank you.
Do you have time for some more spotters?
Yes, we do. We can have a couple more.
Just a minute.
The audience has been very laid back to you. Kindly be active and respond in comments.
Just a minute. It's visible?
Yes, it is.
Yeah. So this 12-year-old girl who had persistent jaundice, and there were 2 transfusions till date. Anyone can, so I would just read out the values for you. Hemoglobin is low and RBC is normal at almost 4 million, and then MCV is low. Nothing wrong with the WBCs. Anyone can say what are the findings with the RBC histogram and the platelet histogram, these two? With clinical suspicion being hemolytic anemia.
Okay, responses for the spotter, please. Case number 1.
Okay, I would just to show another similar case which was there. So you have an RBC histogram which is not touching the baseline, and there are platelets which are going haywire. If you want the morphology, this was the morphology. The question is, what's the next simplest test you can do in this case to get to the diagnosis?
Anyone out there with a response? Even the PGs in the who are presenting can respond.
Okay, let's say as a part of hemolytic workup, they had asked for retic, and you are doing it by manual method. This was the picture of it. Now, any diagnosis or just the findings of what it is?
Dr. Sindhu says hereditary spherocytosis.
Spherocytosis, but you not expect a lot of poikilocytosis in such cases. So, anything you are able to pick with the supravital stain?
Your attention, please. Please do not panic. Thank you.
Dr. Nilima Gupta says it's transfusion related. Anybody else?
Okay, these are golf ball inclusions, and the simplest of the test was a supravital stain. And whenever the only reason why we put this case was whenever you have this fragmented RBCs, such severe poikilocytosis, a transfusion dependent anemia, always think of these are all HPH disease. Okay. Another case where both are of 23-year-old female, hemoglobin is at 18, but PCV is at 36 for one, and one of them has hemoglobin of 17.5 and PCV of 38. What's the likely error that has occurred with this sample? Or is it a pathological process? Any answers? Okay, I would just get you to the picture of the sample. What is it?
No responses so far. Audience is sleeping today.
Anyone who presented, the presenters, any of those who can say what is with the sample? One says hemolyzed, but it's not, it's more of lipemia. So
Dr. Akina says it's a hemolyzed sample.
Yeah, so this is more of lipemia. Whenever the lipemia comes, the turbidity is so much and it can't separate the cells out.
Yeah, that's what Dr. Nilima said. It's lipemic blood.
Yeah. Those were the spotters, and that's from our side.
All right. Thank you, Dr. Pradeep. Shall I request Dr. Jayram sir to make the closing remarks and announce who's the best presenter for the day? Jayram sir, if you're on. Yeah. Jayram, could you please come in and announce the best presenter?
That's a very difficult task, Aditya. I've given a choice. I would say all 5 of them presented very, very well. Is that acceptable?
No. We'll have to choose the best amongst the one.
Okay. Probably given the difficulty of the case and the approach, I would identify Dr. Anusha as the presenter.
Congratulations, Dr. Anusha.
Thank you, sir.
Dr. Anusha is from Kidwai and she presented case number 6. So, any comments from you, sir, before we close?
Nothing. It was a wonderful presentation. Thanks to all the presenters. Thanks to my team for having put together these good cases, and thanks to KCIAPM for this wonderful session. That's it. Nothing more.
Dr. Rakshit, would you like to close it off?
Thanking everyone here from Anand Diagnostics for your presence. We will meet soon. Thank you.
All right. With that, we'll be closing the session. Thank you all for joining us for this virtual slide seminar. It was great. Thank you all.
Thank you, sir.
We'll be closing the meeting now.
Thank you, sir.